Good afternoon, everyone. My name is Andrew Kowalski, and I am a pharmacist at the University of Miami Sylvester Comprehensive Cancer Center with the Myeloma program. And today I'll be presenting our research on tocilizumab prophylaxis for patients treated with relapsed refractory multiple myeloma who are treated with teclistamab, elranatamab, or talquetamab. Start off with a little bit of background information. Recent years there have been shifts in the treatment landscape for multiple myeloma. There are currently 3 FDA-approved bispecific antibodies for use in relapsed refractory myeloma. That includes elranatamab and teclistamab, targeted for BCMA, as well as talquetamab, which is targeted for GPRC5D. These drugs are associated with improved response by historical comparator. However, they are associated with common adverse events, and this includes infection and myelosuppression. And they also carry boxed warnings for CRS, which is cytokine release syndrome, and ICANS, or immune effector cell-associated neurotoxicity syndrome. So although they're more effective, they tend to be associated with a significant toxicity. CRS and ICANS are important because they can negatively impact patient outcomes. They're commonly observed with each of these drugs, and in particular, higher grade 2 or higher CRS has the potential for increased resource utilization and overall poor patient experience and quality of life. This could be due to prolonged hospitalization or readmissions to manage CRS, as well as additional monitoring for subsequent dose administration related to CRS with previous doses. At the time of this presentation, there have previously been sub-studies of larger clinical trials which have reported on the use of prophylactic tocilizumab prior to teclistamab, as well as to the investigational bispecific antibody cevostamab. However, there's also limited real-world evidence for prophylactic tocilizumab prior to teclistamab, but to our knowledge, there has yet to be any systematic study of this approach prior to elranatamab or talquetamab. So the aim of this study was to determine if the addition of tocilizumab as a preemptive rather than a reactive measure could improve the rates of CRS and ICANS without compromising efficacy or adding any additional toxicity. This was a study that included 72 patients who were diagnosed with relapsed and refractory myeloma who were treated at our institution from the time of the first FDA approval in 2022 through the data cutoff in June of 2024. All patients were admitted to the hospital for dose ramp up for each of the bispecific antibodies per the recommendations in the package insert. At the time of admission to the hospital, they were started on infectious prophylaxis prior to the first dose of the step-up dosing for the bispecific antibody per our institutional standards, which included acyclovir, PCP prophylaxis, levofloxacin prophylaxis, and then we also, on an as-needed basis, used GCSF and also used fluconazole if there was prolonged neutropenia, but not for all patients. During the hospitalization, we gave a single dose of IV tocilizumab as a preventative measure, along with the other pre-medications per the prescribing information. This single dose of tocilizumab was added 1 hour prior to the very first step-up dose only. And then patients were observed in the hospital for between 4 and 7 days in line with the recommendations in the individual drugs prescribing information. Looking at our patient population, the majority of patients did receive teclistamab. We also had patients that received elranatamab and talquetamab. The median age was 67, and 29% of patients were age 75 or older. 58% of patients in our study were female, and 24% of patients were Black race, and 35% were of Hispanic ethnicity. The majority of our patients did have a good performance status, 61%, and had an ECOG performance status between 0 and 1, although we did include patients with ECOG performance status of 2, as well as 3 to 4 at 31 and 8%. 76% of patients met at least one exclusion criteria for their respective drug's clinical trial, and we did include patients with high-risk cytogenetics. The median prior therapies were 5, with a wide range between 3 and 15. All patients were triple class exposed, and the majority of patients were pentadrug exposed at 65%. Looking at the results on CRS, prophylactic tocilizumab in our study did significantly decrease the rate of cytokine release syndrome. All grade CRS was observed at 14%. This compares favorably with each of the individual drugs, which range between 56 and 78%. And then also grade 2 or higher CRS, we only observed at 1%, which compares favorably with each of the registrational trials for the individual drugs. Furthermore, we did not observe any grade 3 or higher CRS, which was rarely reported with these drugs without prophylactic tocilizumab. And additionally, we did not give any additional tocilizumab or steroids for an indication of CRS to patients on this trial. So overall, we saw lower severity CRS and at a lower rate than without prophylactic tocilizumab. The time to event analysis for CRS and ICANS shows that most of these events did happen early on during that step-up dose window, which was as expected. These events were mostly also lower grade and severity, as I mentioned. We did see one grade 3 ICANS event that happened later on outside the step-up dosing window. Overall, the impact on ICANS was less clear than that with CRS. We saw overall 8% of patients had ICANS in this trial, which compares similarly to clinical trials, which had between 3 and 9% ICANS overall. But we also did see some grade 3 ICANS, some more higher grade ICANS compared to the clinical trials. On the clinical trials, they did report a little bit higher grade 3 non-ICANS neurologic toxicity, which we didn't look at in this study. So that grade 3 non-ICANS neurologic toxicity ranged between 2.4 and 7%, depending on the drug. Furthermore, our recurrent ICANS rate was 1% in the present study, which is similar to what was reported in the clinical trials for the individual drugs. Looking at the individual cases of higher grade ICANS, we did see 2 grade 3 ICANS events, and each one really illustrates the complexity of the real world cases. One patient had known CNS involvement prior to receiving talquetamab. They found to have a seizure during step-up dosing, and they also were subsequently found to have intracranial hemorrhage. However, ICANS cannot be ruled out in that case. The second case of high grade 3 ICANS was a plasma cell leukemia patient who was on dialysis prior to being treated with talquetamab. She was found to have cord compression after step-up dose 3 and was treated with radiation therapy. Also had confirmed seizures, rhinovirus pneumonia, and disseminated varicella zoster virus infection. However, ICANS cannot be ruled out. Taken together, I think this shows that these real-world patients are complicated, and there's a lot to be known about ICANS and the effect of prophylactic tocilizumab on ICANS. Overall, the safety profile was similar to real-world patient populations. So hypogammaglobulinemia was common. We saw it in 82% of patients, which was expected. We also saw common infections. So 47% of patients had a documented infection. The majority of these were upper respiratory infections as well as COVID or pneumonia. We did see 1 CMV viremia, 1 disseminated zoster virus infection, as I mentioned, and 1 bacteremia. We did not see any invasive fungal infections or PCP pneumonia. Again, we did give everyone PCP prophylaxis on the trial. We did not give everyone routine antifungal prophylaxis. Also, grade 3 or higher hematologic toxicity was commonly seen. Neutropenia was 53% of patients, and the median time to onset was 13 days, although that was a wide range between 123 days. Looking at the efficacy, it seems like this is pretty comparable to the registrational clinical trials and to other real-world patient populations treated with bispecific antibodies in the absence of prophylactic tocilizumab. So it seems that the use of prophylactic tocilizumab does not impact the efficacy. In conclusion, the present data does demonstrate that tocilizumab is effective as a prophylactic approach. However, larger randomized studies are needed to confirm and expand on our results. We did see a lower rate of CRS, and there was only 1% or higher grade 2 or higher CRS, and no episodes of grade 3 CRS or higher, as well as no recurrent doses of tocilizumab needed for recurrent CRS. So all that taken together, it seems that prophylactic tocilizumab is an effective approach to prevent CRS, with the impact on rate of ICANS remaining to be seen. And this is important for patients because, one, it can improve quality of life. So we're seeing lower rates and lower severity of CRS, fevers, things like that. And also it can improve resource utilization efficiency. So the avoidance of grade 2 or higher CRS has the potential to keep patients out of the hospital and limit resource utilization. So overall, I think that's a promising intervention. That being said, I'd like to thank everyone at the University of Miami Sylvester Comprehensive Cancer Center and especially the Myeloma Institute, with a particular thanks to my mentors for the project, Dr. Ola Langren, Deacon Kasanjian, and Benjamin Diamond. And thank you. That's all I have for today.